Liebe Kolleginnen und Kollegen, liebe Freunde des Amboss Studiendiagramms, Marcus at Home welcomes Dr. Richard Glassock in Los Angeles, California, with whom we would like to discuss, firstly, some specific aspects of infection-related glomerulonephritis, which is a terrible word for German tongue, so I will refer to this as GN in the following. And secondly, giving his lifelong contribution to academic and clinical nephrology, some more general aspects on glomerular disease, and maybe even beyond that, on the past, the present, and the future of nephrology. So it's the first summer morning in Southern California. You could be out on the beach this morning watching the sunrise. Therefore, it's really a privilege and a blessing for us to have you with us, Dick. So thanks for being with us.
Thank you very much, Gunnar. My pleasure.
Dr. Glassock is an emeritus professor at the University of California, Los Angeles, UCLA. He is, among many other activities, co-chair of some KDIGO-Guidelines. He is co-author of the present and also on the previous GN guidelines, and he's section editor of Up to Date. Now, I could spend 30 minutes or so listing all the contributions of you in this field, but I'm quite positive that our colleagues do not want to hear some German doctor speaking about a legend of nephrology. They want to hear the legend himself speaking about nephrology. And just let me end up this introduction by citing some colleagues, I think, from the Egyptian Society of Nephrology, who once introduced you as the father of nephrology. And I was very impressed by their statement that you gave talks in around about 95 countries around this world. So somewhere between Pope Francis and the Queen of England, I guess. So my co-moderators are Dr. Diefenhardt from Cologne, Germany, and Dr. Morel, who's presently in Bordeaux, France. So a second person at the West Coast, but not the West Coast of the States, but the West Coast of Europe. My name is Gunnar Heine from Frankfurt, Germany.
I would like to start, if that's okay with you, and try to give a little overview to our viewers. So there are some different types of glomerulonephritis which are associated with an infection. Could you tell us a bit more about which different types we should differentiate?
Well, thanks, Sarah. I think you started out with an excellent question. Virtually any infection that is known in human medicine can afflict the kidney in some way or another. Bacteria, virus, fungal, parasites, almost any. Of course, there are some that are more common than others. And one that is in particular important from the historical perspective is the Streptococcus. In fact, if you go back in the early literature in the 1900s or so, you'll see many papers written on nephritis associated with scarlatina, scarlet fever, often with pharyngitis, called post-streptococcal glomerulonephritis. The post part of this description is that it follows the infection, but after the infection has been eradicated or spontaneously cured. It didn't take very long to recognize that this is due to an immunologic reaction to the organism, and perhaps simultaneously with autoantigens of the host of the infection. And post-streptococcal glomerulonephritis, particularly in its epidemic form, was a relatively common occurrence in the days before antibiotics, particularly in areas with low hygiene or in crowded conditions. Nowadays, with antibiotics and with better hygiene and recognition of the importance of cross-infection with this organism, post-streptococcal glomerulonephritis has become relatively uncommon, particularly in the high-income countries, but it still remains in both endemic and epidemic forms in many regions of the world. We've learned a lot about post-infectious glomerulonephritis, mostly, but not always, due to streptococci. It is almost certainly an immunologic reaction. However, the exact details still elude us. For a long time, it was believed that it was due to the deposition of immune complexes of antibody and the one antigen or another of the organism. Now we understand that streptococcal proteins have a unique ability to activate complement, particularly when they're deposited on tissue surfaces. And some streptococcal antigens have affinity for the glomerular capillary wall, where they can bind, activate complement, induce inflammation, but relative paucity of an antibody response to the organism. So we have to look at post-streptococcal glomerulonephritis as a disease of activation of complement, particularly through the alternative pathway, and perhaps to the formation of immune complexes that deposit in the glomerulus. The hallmarks, therefore, of post-streptococcal glomerulonephritis are the presence of intense complement deposition, particularly C3, and the formation of immune complexes containing immunoglobulin G and other immunoglobulins. These have a tendency to localize as humps, extravascular humps, large electron-dense agglomeration of immune complexes, and with minimal or moderate immune complex deposition in the mesangium and subendothelium. So that combination, intense complement activation and the formation of immune complexes with humps and exudation of inflammatory cells and proliferation, are the hallmarks of post-streptococcal GM. Okay, a long description, but an important disease historically as well as clinically.
Perfect, thank you. But there are also some forms of glomerulonephritis that are associated with an ongoing infection, I think.
Yes, the terminology can be a little bit confusing here, but in general, people now use the term infection-related glomerulonephritis rather than post-infectious glomerulonephritis. Because in infection-related glomerulonephritis, there is ongoing infection, and the infection itself, rather than some sort of post-infectious complications, is central to the pathogenesis of the disease. I suppose infective endocarditis would be a classic example of this, where an organism infects the valves of the heart, sheds the antigen into the circulation, an immune response is formed, immune complexes occur in the circulation, they deposit in the kidney and provoke a disease. Some of these patients have very severe forms of glomerulonephritis. For example, crescentic glomerulonephritis, associated with a rapid loss of renal function, where the others have less severe forms of kidney disease, more of an indolent process with proteinuria and hematuria and slow evolution of loss of kidney function. But the central role of the active infection is common to all of these. Now, the organisms that are involved in this form of disease are much more widespread than in post-streptococcal disease. Staphylococcal is perhaps the most common. Staphylococcal endocarditis, staphylococcal bacteremia, staphylococcal abscesses. But other organisms, some more difficult to culture from the blood, like Borrelia, Bartonella, Q fever, in which the blood cultures are negative. And the only way to diagnose the disease is to suspect it and do serology. The diagnosis of infective endocarditis, of course, rests on the demonstration of vegetations on a valve. And in this case, you must do transesophageal ultrasounds because the non-transesophageal have too low sensitivity. So you need to think of culture negative endocarditis and serology and the use of transesophageal. Unfortunately, some of these patients are very difficult to treat. They may be abusing drugs intravenously, so they're constantly exposed to bacteria. They may be immunocompromised. The degree of destruction of the valve may be so severe that their life is threatened by cardiovascular complications. And the vegetations can destroy the function of the valves themselves, leading to severe aortic or tricuspid insufficiency, complicating the picture severely. Now, I want to emphasize that there are other bacterial infections that can provoke glomerulonephritis, and perhaps now's a good time to talk about Staphylococcal-associated IgA-dominant glomerulonephritis. A very long word to describe a simple association between infection, often staphylococcal, often mild, a skin abscess, a boil, an infected toenail, a postoperative wound infection. Somehow, by virtue of the ability of the staphylococcal organism itself or its cell wall to activate IgA immunity, leads to a form of IgA nephropathy. Not the primary form of IgA nephropathy that we know so well that causes hematuria and proteinuria, but a secondary form of IgA deposition disease, which follows or accompanies these infections. And most of these patients who have this staphylococcal or other organism-associated IgA-dominant form of glomerulonephritis will have some site of active infection, which should be sought for because treatment of the underlying infection is far more effective in managing the disease than attempting to manipulate the immune response in a favorable way and safe way in such patients. Diabetics are notoriously susceptible to this IgA-dominant form of infection-related glomerulonephritis, and unfortunately, their prognosis is not very good. Some of these patients will wind up in end-stage renal failure, and as the KDIGO-Guidelines in infection-related disease will point out, the treatment of these patients is highly uncertain. No control trials have ever been done, and the risks of exacerbating the underlying infection with immunosuppressive drugs is reasonably high. So the window of therapeutic opportunity is very narrow.
Yeah.
And the judgment as to whether a patient should or should not be treated with immunosuppressive agents has to be made on a highly individualized basis. Therefore, there are no algorithms, no recommendations at all for the treatment of IgA-dominant infection-related glomerulonephritis in the forthcoming KDIGO guidelines because there's too much uncertainty and such sparse literature that we cannot make an evidence-based judgment.
So as you've said, we might be able to differentiate on the one hand side post-infectious glomerulonephritis that is often caused by a streptococcal disease, and on the other hand side, infectious-related glomerulonephritis that might be caused by staphylococcus or other parasites.
Well,
and it is quite, sorry.
The differential,
yeah.
The differential diagnosis is not easy.
Yeah.
Because many of these diseases can appear clinically similar, often even serologically similar. Kidney biopsy is helpful in making a differentiation, particularly when you use light, electron microscopy, and immunofluorescence, but there are still patients with overlap. The differentiation between infection-related glomerulonephritis and another entity called C3 glomerulonephritis can be extraordinarily difficult in individual patients. Now, sometimes the serological laboratory can help in making the differentiation by looking at the details of the complement pathway. Sometimes genetic analysis can help because genetics don't seem to play a major role in infection-related GN of, say, infective endocarditis or post-streptococcal, whereas in C3 glomerulonephritis it does. I would say that that serology and genetics together are perhaps the best way to make a clear clinical differentiation if you don't have, say, a positive blood culture or a streptococcal organism isolated from the throat or a positive anti-streptolysin antibody. I think serology and genetics is the best tool.
And it is important to use the correct terminology when regarding those different diseases. Okay, because it has a consequences for therapy, for instance. There are different pathogenesis, as you've said. Do you think that the KDIGO guidelines will regard those different terminology terms, or?
No, the guidelines are fairly clear in making the distinction between a post-streptococcal or a post-infectious GN and an infection-related GN. Obviously, by definition, a post-infectious glomerulonephritis will not respond to antimicrobial therapy. The infection is gone. It's the immunologic aspect of the prior infection that's important. Whereas in infection-related glomerulonephritis, identification of the infection, the organism, will be key to treatment. Unfortunately, and I think the KDIGO guidelines emphasize this, the evidence base of treatment is so sparse in infection-related glomerulonephritis that it's impossible to make evidence-based recommendations for management. There are some practice points, some tools that can be used in individual patients to refine the diagnosis and to lead to an appropriate management. But immunosuppressive treatment of infection-related glomerulonephritis has no substantial background of randomized controlled trials. So the committee, the four of us, the team, Dr. Adler, myself, Dr. Rave, and Kelly Burge, the four of us came to the conclusion that it was better to describe how to go about making a correct diagnosis than to emphasize what we don't know about treatment. And believe me, it is a very serious deficit. And no one wants to treat a patient and have an unfortunate fatal outcome related to treatment. And there is a real risk in these seriously ill patients when using immunosuppressive agents in infection-related. Diagnosis is key. Now, some infection-related diseases are easily treated with simple, safe antibiotics. For example, Borrelia and Bartonella. easily treated, difficult to diagnose, but easily treated. There are some, of course, staphylococcal organisms that are highly resistant, extraordinarily difficult to treat. But the importance is to diagnose the infection, select the best available antibiotic, treat appropriately, and hope that the kidney disease will eventually go away.
Thank you. Thank you so much.
If we could just go back one step and look at the post-streptococcal GN once again. You clearly stated how the pathogenesis we think is going on, but what I never really understood is why is there this latency phase between the acute infection with streptococcal and then weeks later get the acute glomerulonephritis, which is not seen with staphylococcal, for example.
Right. That's a very good question. I'm not sure I have a great answer for it. You might say, well, it takes time for the immune response to develop. This is a primary immune response, not an accelerated or a secondary immune response. So it takes a week or 10 days for the antigen to activate the T and B cell apparatus and produce antibody. And after all, it is the antibody that is doing the damage, not the organism itself. However, that's a little hard to place into context if the organism is producing an antigen that binds to the kidney and activates complement. Why should there be such a delay? Well, there is probably an interplay between the antibody arm of the response and the complement activation arm of the response. Perhaps in the absence of an antibody response, the complement activation is minimal, and therefore the disease is not widely expressed. I don't have a good answer to your question. It's an excellent one, and the latent period is unequivocal. I mean, it is 7 to 14 days for a throat infection and 14 to 28 days for the skin infection. I think my best answer is that it takes time for the immune response and the complement activation to occur in a fashion that is sufficient to produce clinical manifestations. We don't have biopsy information in asymptomatic patients. So we have a gap in our knowledge as to what is going on prior to the first overt manifestations of the disease. And there may be a lot of changes going on in the kidney that we don't appreciate because they have no outward manifestation. That gap will probably never be filled. Right. Because it's very difficult to justify doing a kidney biopsy in an asymptomatic patient. Right. But an excellent question. I wish I had a better answer.
That's okay. Maybe one last question from my side for the post-infectious GN. You said we don't really have randomized controlled trials, so we don't really know how to treat these patients. Usually the GN resolves within 1 week or 2 weeks. What would you suggest we do with patients that have these rapid progressive forms of GN?
Well, fortunately, they're uncommon, but you're quite correct. A crescentic disease and rapidly progressive glomerulonephritis can complicate virtually any of the post-infectious as well as infection-related forms of glomerulonephritis. This is a manifestation of the severity of the injury to the capillary wall. If the injury is severe enough, gaps or holes will appear in the basal membrane, allowing fibrin and cells to escape into Bowman space where they generate crescents. And crescents not only compress the capillary wall and prevent urine from being formed, they obstruct Bowman space and prevent any urine from getting into the proximal tubules. So severe crescentic disease can be looked at as a form of intranephronal obstructive uropathy. In this case, it's this massive agglomeration of fibrin and cells in the Bowman's space that causes oliguria and anuria. And now, if you don't have an ongoing infection and you have crescentic disease, there might be a rationale for treating a patient with anti-inflammatory agents such as steroids, or even immunosuppressive agents such as cyclophosphamide or rituximab or something else to abort the formation of crescents and to accelerate their resolution. Unfortunately, we have no randomized controlled trials in these diseases to prove that that treatment is in fact efficacious. We have anecdotes, yes. There are reports in the literature of successful treatment. However, that is a publication bias. Nobody reports failure of these treatments. So we have this biased idea that steroids and immunosuppressants can be efficacious, and I think they might be. The problem is how to choose the patient and when to give it and how intense should it be and how long should the therapy be. We really don't know. Therefore, it requires clinical judgment, willingness to tolerate uncertainty and risk, and most importantly, the fragility of the patient and ability to withstand these potent immunosuppressive agents. No recommendations are made in the clinical practice guidelines. All I can say is I have used them personally in the past, and I have had occasion to regret that decision, as well as occasions to applaud my decision. So it's an unfortunate area of high uncertainty, moderate to severe risk, but the yield is, when it's successful, of course, avoids dialysis and prevents the patient from developing end-stage renal failure. So it's much more important in a young person.
Right.
A 75, I mean, I don't want to be age discriminatory or show structural ageism in my comments, but the risk to the patient does depend upon age, and the benefits are much higher in the younger as compared to the older population.
I would maybe finalize this discussion on the post-streptococcal GN by 2 or 3 clinical questions again. So what kind of diagnosis should we do? Because there are a lot of antigens against Streptococcus, but it's always difficult to pick the right ones. And I think it always some kind depends on the laboratory which we work, whether we take one or the other. Do you have any preference?
Well, yes, there is, I think, good evidence-based guidelines here. If the streptococcal infection is pharyngitis, the patient gives a distinct history of a sore throat, particularly an exudative pharyngitis, documented by an inspection of the pharynx showing a purulent exudate, and you suspect a streptococcal infection because other members of the family had similar symptoms, then anti-streptolysin O is the preferred serological response because the antibody response in pharyngitis is very prominent, highly reliable. It's 80% sensitive and 90% specific. Now, if you have a patient who has no pharyngeal symptoms, but had a small impetigo on their wrist, or had a streptococcal infection of a wound, documented, streptolysin O is of no value because they don't make a streptolysin O. You have to use an anti-DNA ACE. Now you can capture both antibodies in the same test by using what's called a streptozyme test, which combines both antibodies in the same test. But if that's not available, you have to select the serological testing according to the symptoms and signs of the patient. Now, occasionally, of course, you will find a patient who has no streptococcal antibody response, yet you document what looks like streptococcal glomerulonephritis, and it's possible that those patients had an evanescent infection. It may have been treated early with antibiotics, preventing the antibody response, but not preventing the glomerular disease, and that certainly can occur. Biopsy is not often done in patients with classical post-streptococcal glomerulonephritis. That is a positive anti-streptolysin O or anti-DNA ACE or streptozyme, and a history of impetigo or a sore throat, because the biopsy finding is not going to make any difference in management. You're going to treat the patient the same way, unless they have rapidly progressive glomerulonephritis. If their serum creatinine goes up, doubles every day, yes, then I think a biopsy. But in the normal case, it's fluid retention, hypertension, hematuria, proteinuria, which takes a month or two to resolve. And treating those patients makes no difference. You treat them symptomatically of their edema, their hypertension. So biopsy is not very often used anymore for diagnostic purposes.
And do these antigens go back to normal after some months or years? So if I had an infection back in the 70s or so?
Good question. The anti-streptolysin O can last a month or two, depending on the height of the titer, but it usually will eventually return to normal. Same is true with anti-DNA ACE. An elevated level is not pathognomonic of post-streptococcal glomerulonephritis, unfortunately. Higher levels can be seen in patients with Henoch-Schönlein purpura, IgA vasculitis. So its specificity is not 100%, but most of the time the serology returns to normal within weeks or months. Unfortunately, the urine does not. These patients can have persisting hematuria and some degree of proteinuria for up to a year. If it persists beyond a year, I would think that they may not have had really post-streptococcal glomerulonephritis. They may have another disease. So persisting urinary abnormalities, proteinuria or hematuria, even if the serology returns to normal, should raise the suspicion of other diseases. For example, IgA nephropathy, C3 glomerulonephritis, Alport syndrome, any of the causes of persisting hematuria.
So when it comes to urine analysis, I was always kind of surprised that we do have so clear definitions of nephrotic syndrome, but we read a lot of nephritic syndrome in the field of post-streptococcal GN also, but I never actually found a clear definition. So what are your ideas? Should we use this term nephritic syndrome, and what do we mean by stating nephritic syndrome?
Well, a part of the nephritic syndrome that relates to hematuria is that it must be glomerular hematuria. With nephrotic syndrome, we have a quantitative definition. It's arbitrary, and it's linked to historical use of greater than 3.5 grams of proteinuria per day, and a serum albumin less than the lower limit of normal for the laboratory. For hematuria, of course, and the nephritic syndrome, we must always state that this is glomerular in nature. In other words, it has acanthocytes, typically greater than 5%, these Mickey Mouse-like looking cells with projections off their cell membrane, or red cell casts. Now, normomorphic hematuria is not a part of the nephritic syndrome. That indicates a bladder or lower tract abnormalities. So I don't like to consider nephritic syndrome just hematuria and proteinuria of any magnitude. I like to say glomerular hematuria and proteinuria of a glomerular origin, which would mean typically albuminuria, increased fractional excretion of albumin, not lower molecular weight proteins, and these typical red cells associated with glomerular injury, acanthocytes and or red cell casts.
Whether creatinine is normal or increased, so the term can be used with either.
The serum creatinine level is not really an integral part of the definition of nephritic syndrome or nephrotic syndrome. GFR can be normal in both circumstances, although typically in the infection-related diseases, the serum creatinine does tend to decrease. Some degree of renal and functional impairment, but post-streptococcal GN, many patients have perfectly normal serum creatinine. They retain salt and get hypertensive, but they can have perfectly normal serum creatinine. It's a bit of a paradox that you can have such profound symptoms in the absence of much change in GFR. But you have to remember that a lot of things can go on in glomeruli that don't impair glomerular filtration. And anytime you have a disease of the glomerulus, it can adapt to the injury by increasing the hydraulic forces available for filtration and maintain filtration at a normal level, but at the cost of an increased glomerular capillary pressure. And you can't define increased glomerular capillary pressure on the basis of a serum creatinine level or an eGFR. You have a perfectly normal eGFR with a marked increase in glomerular capillary pressure. And remember, eGFR and serum creatinine don't measure nephron number. And you can have a sizable amount of your nephron mass lost and still have a perfectly normal serum creatinine.
So my very last question on the post-streptococcal GN would be then, if complement is of concern in the development, do we expect one of these novel treatment strategies affecting complement to change therapy in the future?
This is an excellent question, and one which I would love to give a positive answer to, because I think the field of complement inhibition as a therapeutic tool may augur in another golden age of nephrology. These are powerful agents, and they may alter the course of many, many kidney diseases. There are at least a dozen different companies examining complement inhibition as a therapeutic tool. Preliminary data is highly encouraging, but of course we have no successful phase 3 trial, and not a single drug, with the possible exception of avocapan for vasculitis, has reached a level of approval or near approval. So we have a ways to go, probably several more years before we'll have a drug that inhibits complement that can be used in glomerular nephritis. The subjects of the trials in progress are not post-streptococcal glomerulonephritis or infection-related glomerulonephritis. None of the trials currently in progress involve those patients. They involve patients with IgA nephropathy, C3 glomerulonephritis, lupus nephritis, hemolytic uremic syndrome, other thrombotic macroangiopathies, and vasculitis. All important diseases, but none necessarily linked to infection per se. The drugs are being evaluated in these patients because they're more common diseases, so you can accumulate patients for a trial. And the risks of complement inhibition involve aggravation of infection. So it makes logical sense to prove the safety and efficacy of a drug in a group of patients who are not at high risk for infection. Use of complement inhibition in a patient who is already infected, magnifies the risk, potential risks, enormously. So I don't see complement inhibition therapy on the horizon for infection-related GN. It may eventually happen, but I don't see it as a near-term future prospect.
So thanks a lot for all these ideas on post-streptococcal. So we talked a little bit about Staphylococcus. We could talk about many other germs, but we are aware of your time. So we would suggest, as it's summer 21, to focus on one last virus, in this case, surely on SARS-CoV-2, and would be very interested to learn your ideas, because there have been a lot of discussion on the role of both the virus and vaccination. Each day we see a number of publications. Right. Just this morning I found 4 letters in Kidney International. So you saw a lot of infections coming and going. What are your ideas?
Well, we have made tremendous strides in the viral form of glomerular injury, HIV, HBV, HCV, all largely controllable diseases now for which we have a great number of drugs that are effective in the treatment of HIVAN, in the treatment of HCV-related glomerulonephritis and HB-related glomerulonephritis. COVID appeared on the scene about midpoint in the development of the KDIGO-Guidelines. And by the time the KDIGO-Guidelines were finished, the epidemic was still in full swing. And it was only becoming apparent that COVID could produce glomerular disease, not by direct invasion of the kidney. I think that's now still in serious doubt as to whether it is a direct cytopathogenic effect of the viral infection of the kidney, but rather the response. The virus induces a prothrombotic state, and therefore there are instances of thrombotic microangiopathy reported in association with COVID. Fortunately uncommon, but they do occur. COVID elaborates a profound increase in interferon levels. It promotes interferon release, and we recognize that for ApoL1 risk allele bearing individuals, increase in interferon can be a second hit and produce marked glomerular injury, manifesting as collapsing glomerulosclerosis. COVID can also induce widespread active immunity. So anybody who is predisposed to anti-GBM disease, to lupus, to antibody-mediated vasculitis can develop these diseases after active immunization with COVID. Anti-GBM disease, ANCA vasculitis, and lupus have all been reported following active infection. And now with vaccination appearing, which did not occur until after the guidelines were written. We had no knowledge about immunizations because they didn't occur until December of 2020. We recognize that immunization against the virus can provoke the same panoply of findings. Immunization can activate lupus, can activate anti-GBM disease, can activate ANCA. Unfortunately, it's very rare, but it does happen. Probably some genetic predisposition exists. We don't know that for sure. So COVID is an important cause of infection-related glomerulonephritis, and it's almost all due to the immunological effects of the virus rather than the active replication of the virus itself, as proven from the vaccine experience. We have zero recommendations for treatment because no controlled trials have ever been done in the treatment of COVID-related glomerular disease. All we can do is base the treatment on what the response looked like. So if it's vasculitis, we treat it with rituximab, but that impairs the immune response, so it's a double-edged sword. For lupus, we would treat it as any flare of lupus, recognizing in an active infection that might aggravate the COVID disease. And for thrombotic macroangiopathy and vasculitis, we would treat the patient according to what they had, not necessarily related to COVID. It's an emerging disease. We don't have the answers yet. I expect in a few years we'll know a lot more, but by that time the disease hopefully will be gone. Hopefully.
So maybe from my part, one last question before I give the mic back to the next generation of nephrologists, so Paul Diefenhardt and Sarah Morell. You have followed nephrology for 6 decades, and I just learned last week that you started your career in kidney disease even before the term nephrology has been coined. So you have even been a pre-nephrologist, actually.
Yeah.
So when you look back on the last decade, so the term between the last GN guidelines in 2012 and the present one in 2020, what are the major changes beyond the field of infection related GN, and maybe where are the major missing links?
Well, if I had to summarize, the difference over the last decade is that we're moving rapidly towards a personalized approach to treatment of glomerular disease, because we now have tools to discriminate what used to be one size is now many different sizes. Let me use membranous nephropathy as the example. 10 years ago, when more than 10 years ago, when we started the first form of the guidelines, membranous nephropathy was viewed as a single disease based on histology. We had no idea that it would be actually caused by 8 or 9 different antigens. Now we know that, and now we are able to classify individual patients based on their antigen and their serological response. This has led to the development of what I think is a highly effective form of treatment, rituximab. Now, I must mention here, I was at one time a consultant to Genentech Roche, which manufactures rituximab. Nevertheless, I think the data is now strongly emerging that we have, for membranous nephropathy, a very effective form of treatment using anti-CD20 monoclonal antibodies to interfere with the immune response. That's a big difference in just a decade, going from what was in effect a pattern of injury-based diagnosis and treatment to a specific antigen antibody-based treatment of an immunological disease affecting a single organ, namely membranous nephropathy. Progress hasn't been quite as rapid in the other diseases. We're treating IgA nephropathy roughly the same way now as we did 10 years ago, but the pipeline of new drugs is enormous. And I think the promise for changing the dynamics in the treatment of IgA nephropathy is marked. As you may know, we now have a new drug for treatment of IgA nephropathy that has nothing to do with immunology, gliflozin, dapagliflozin in particular, which has a pronounced beneficial effect on the natural history of IgA nephropathy, largely acting hemodynamically within the kidney, having nothing to do with IgA immune responses, but the effect is really profound. That's going to alter how we manage IgA nephropathy going forward, in my opinion. Minimal change disease, yes, we've made some progress. We've refined the approaches to management. Focal and segmental glomerulosclerosis is a mess, a total mess. It's getting better, but it's pretty clear that basing treatment on a histological lesion does not work. So we're moving towards the same approach to FSGS that is present in membranous nephropathy, treating it as a pattern of injury caused by multiple events. And treatment has to be directed to the underlying event, not to the histology. I think those represent the major changes in the field. Vasculitis, of course, is also very different now than it was a decade ago. The progress has been sufficient to cause, 80 or 90% of the patients to be at least treatable. And we're probably preventing end-stage kidney disease to a very large extent in these patients. So I'm very optimistic that we are made great strides, and I think the future of nephrotherapeutics or glomerular therapeutics is very, very bright. And I'm extremely excited about what will happen as these new drugs come on the market, and we do additional randomized controlled trials that will have a good solid evidence base for what we do with patients with glomerular disease in the not too distant future. It's a great time to enter the field of nephrology. The toolbox is getting bigger, more complicated, but I think like oncologists, we will have a lot of opportunities to help patients going forward.
Right. Maybe I could ask one last question from my side, a personal question. I don't know how it is in the US, but at least in Germany, if you look at young doctors or students coming out of med school, there's an increasing number of young doctors trying to do only clinic and trying to care for the patient, and the people that try to do both clinical research or basic research and caring for the patient is decreasing. I think might has to do with more work on the ward, more administrative work, and less time to do both. But also because, I mean, it's getting more complex, like you said, every year. Would you think that it's still desirable in the future to trying to do both, or would you rather recommend focusing on one road, either doing basic research or trying to become a good doctor and care for your patients?
Well, making a career out of basic research pretty much means that you have to forego clinical medicine. Basic research is an intense laboratory-based experience in which you have to gain comfort and skills in the use of tools that are not necessarily complex, but demanding in the sense of testing hypotheses. So if one has the curiosity, the ambition, and the patience to enter into basic research, I think they must devote themselves exclusively to that enterprise, at least for a period of time. This basic scientist interested in nephrology question is not likely to be a large contingent of the total fraction of individuals pursuing nephrology as a career, but they are absolutely necessary for future progress. If we lose a generation of basic scientists in nephrology, it will set back our field by decades. So we need to nurture, protect, and help young people who show promise, interest, and ambition in fields of basic science by getting them into good laboratories with a solid commitment. Now, what do you do with individuals who say, listen, I can't do basic science. I'm not a laboratory person. I want to work with patients. I never want to separate myself, even for a short period of time, with exposure to patients. There are opportunities for a promising research career in such patients. Epidemiological research, which does not require a wet laboratory, but it requires a database and a computer, and clinical trials research. I would say the future of clinical trials research is extremely bright. A lot of opportunities, not only in academia, but in industry. The commercial industry wants to attract bright young people into devoting a professional career to the development of a portfolio of drugs. And there are many commercial companies that have now identified nephrology as a sphere of interest. Not only minor small biotechs, which may only have one product, but big pharma that has, multiple drugs in testing or in commercial application. Those two areas offer great opportunities, and I think the promise in both areas is so great that one ought to be able to energize young people into pursuing that career. Now, of course, what they worry about is the financial protection. Can I write a grant every 3 months and assure that it will be funded in times when grant applications are not always approved? Well, I would say to them, yes, there are challenges, but if you're in a good system and you have a good mentor, you will be protected because the mentor wants you to be successful. You're not in it alone. You're a part of a team. And if you join the right team and you have a good mentor who understands your fears and your ambition to succeed, you will have the opportunity to succeed. I can't guarantee that you will succeed, but you'll have the opportunity. Now, clinicians who have no interest in research should, I think, personally commit themselves to be a supporter of research. They should refer patients to ongoing clinical trials. They should engage themselves in a center of excellence for clinical trials as a participating partner. They shouldn't just isolate themselves from the real world of ongoing investigation, even though they're committed 100% to their patients' care. They must recognize that a lot of patients, there are no treatments, and they have the ability to help develop new treatments by engaging as a collaborator in a research enterprise. Even though they may not be the intellectual leader, they make it possible for the ideas of the intellectual leader to really come to fruition. Because without patients, willing patients and volunteers, it's very difficult to move the field of therapeutic research forward. That's kind of a summary of where I would put it. I hope I've covered your question.
Thank you very much. Yes, you did. Yeah, sure.
I have a very last question, if that's okay. What makes a good nephrologist, in your opinion? Are there certain character traits that you need or certain qualities?
Well, I've had very good luck in being associated with very good nephrologists for a long time. So I've seen some of the best. And the qualities that I see in the best nephrologists, first of all, are a dedication to the individual patient. Always thinking about the best interests of their patient, not the economics of the equation, not how much money they will make or what will happen to the system, but the patient has to be the center of all of the best nephrologists. Two is curiosity. never being satisfied with a simple answer to a complex question, and considering patients as a mystery to be solved through curiosity. And third, I think, is the best nephrology knows the literature very well. They read, and they read critically. They don't read the abstract, they read the whole paper. Not every paper, but those that they're in particular interested in. And when they see a patient, they go back to the literature and to the books. Now, I think Ozer was right. The key to medicine is at the bedside, and that a person who learns medicine only through the books is not a good doctor. But an individual physician who offers care only at the bedside and doesn't have the curiosity to go to the source of knowledge is making a big mistake. So curiosity, dedication to the patient are two of the important elements of a good nephrologist, in my opinion.
Thanks.
So thanks a lot. That was really a blessing for us to have you, and thanks a lot, not only for 1 hour of a YouTube interview or 1 year of GN guidelines, but actually 1 life in nephrology. And again, when you started, advanced CKD was a 100% fatal disease.
That's
so
right.
People you have been treating were dying virtually within weeks or months. And it's your generation who helped these people not only to survive, but to pursue a life with a very good quality of life, to choose between different treatment strategies. And it's really for younger people like me, or even younger people like my 2 colleagues, really fascinating to meet people like you who really moved this field for so long a time. So we are very grateful to have you, and we're looking forward to hearing much more from you in the next years, and maybe 1 year again meeting you at a conference when we are able to go to the States, or you can come back to Europe. So thanks a lot, Dick.
Thank you.
Thank you. And let me emphasize that it's been an exciting journey. And actually, even at my advanced age, I get excited about the future. So it builds on itself. And I envy those people who are starting early, because I know they're going to have a wonderful and long journey, and a very satisfying one, just like me. Okay, thank you very much.